Okay, hey guys, this is just a kind of like a trial run to see if this actually works. So my plan is to go through some of my OB notes about some things that she said that she definitely wants us to know, and then I also want to go through maybe just like some blood pressure meds so we can start working on the pharmacology. I'm not sure, I'm not exactly sure how this is going to work since this is the first time. Um, and maybe if there's like things that you guys don't like, you can kind of like tell me, and then we can kind of make improvements from there. Just as a little bit of a heads up, I do use crude humor in my to help me remember things. So if you don't like it, or if it's just something that kind of offends you, then maybe you don't want to pay too close of attention to my studies then, because it's not something like I talk about like openly an awful lot, but it is something that I use quite frequently to help me remember things, because what I learned in psychology class is if your brain really likes things that are weird, crazy, and just things that just kind of like things that are inappropriate. So if you kind of like store information in like those kinds of forms, then you're more likely to recall it. So that's kind of what I use, and so far it's kind of helped me. So this will just be like a normal study session. So just go through here. So one thing that she wanted us to know for maternal child is the powers. So the powers in labor, they're composed of contractions and maternal pushing. Those are two things that she wanted us to know. You have the 4 P's, you have the powers, so you have the contractions and maternal pushing, then you have the passage, and that's basically your vagina and the mom's pelvis. Then you have the passenger. The passenger is the fetus, the baby, and that some things you want to know about that would be the presentation and the position. Then you have the psyche, which means like anxiety, fear, fatigue, pain. The labor experience she mentioned is individual to each lady, so that's something that you're going to want to keep in mind. And also, like if it's a first child, then they're probably going to be more stressed about it than if it was like their second or third. So you probably are going to want to just like be a little bit more like teaching and compassionate to like a first time mom, because you'll probably be a little more anxious. Okay, so let's see what else I have here. And then the way you tell the measurement of the baby through the pelvis, your landmarks for those are the Ishmael spines. So if you can see on that PowerPoint, you're probably going to want to like make sure that you like at least know where those are, what they're used for. And babies that are sunny side up, those are extra painful for the mom just because the placement isn't normal. So one thing that really helps with that, she said, is sacral pressure. So if there's like a question, it's like sunny side up, I think it's occipital, what was it? I think it's OP. Then it's like extra painful, so that you'll want to do like sacral pressure, and maybe like something like position changes to try to get the baby to rotate in there. And then also, like if the baby's head is over 14 inches in circumference, you're going to do a C-section. I don't know if that's something that you need to know, but it's something in my notes, so. Okay, so yeah, occipital posterior, sunny side up, they're going to be painful. Use sacral pressure to really help with that pain relief. You want an OA presentation. That means occipital anterior. And that's just because the baby's head can like fit through the pelvis better. Alright, so let's see here. Increased secretion of oxytocin helps labor get started. So some of the stuff in my notes is nipple stimulation, orgasm, sex, stuff like that. So there might be like a question on that since she mentioned it. Okay, just be something to keep an eye on. Okay, so here's something I have down. So true labor and false labor. The conclusive difference between true labor and false labor is progressive effacement and dilation of the cervix. So some women do not have symptoms of typical true labor. The patient should enter the birth center for evaluation if she's uncertain or has concerns. So this is the PowerPoint, has a star on it. Probably want to pay attention to it. So, and there's also a chart. And let me see where the chart is. Which chapter is it? Okay, so there is a table on page 229. You're probably going to want to take a look at it. It has a star on it. So you do a sterile vag exam, so you check the dilation and effacement and station. And the station you check according to the Ishmael spines. Okay, stages of labor. So here's another one. Okay, so the first stage of labor, you have effacement and dilation, and there's a couple different stages in that. So you have the latent phase, which begins when you have 3 to 5 centimeters dilation. Then you have the active phase, which is 4 to 6 centimeters dilation. The transition stage phase is 7 centimeters to complete dilation, and that's the fastest. I was at a clinical one time, and for the longest time, the mom was at probably like 4 or 5 centimeters, and she was there for a couple hours. But then when they checked her again, she was 9 centimeters. So the latent phase is probably the longest. The transitional phase is the shortest. That's something you should probably know. So that's the first stage of labor. It's got 3 phases in it. The second stage of labor begins with complete dilation to birth. So they're gonna be probably like 9 centimeters, and the baby's born. And then the third stage begins with birth to expulsion of the placenta. The fourth stage is delivery of the placenta through 1 to 4 hours after birth. Yeah. Push if dilated at 10, otherwise blow off urge to push. So, okay, I guess complete dilation they consider as 10. A clinical, they considered it more like 9. So the reason that they want to do those that breathing technique where it's like, and then you just like when they get the urge, is because it helps like with the glottis, so that they don't like have the straining when they like feel like they just like kind of like, it's part of the pushing process. It gets rid of that like urge to. It helps get rid of that urge to push when they blow off. And the reason that they have that done is because you don't want to have them pushing when it's like 7 centimeters, 8 centimeters. Definitely not when it's 5, because the baby's gonna get stuck. It's gonna have extra like pushing on it. It's not gonna help it. It's gonna reduce the placental transference of oxygen and nutrients. So that's not gonna be good. And also, like, if the baby actually does pass through, then she's probably gonna have like a torn cervix or something like that. So you don't want her to actually start pushing until it's 10. And you can go to labor when in the active phase. And the active phase is the second phase of the first stage of labor. A little confusing, but women who have given birth previously go quicker. And then which side to the mom? So this chart here, which side to the mom? So the shiny side is the one that's attached to the baby, and that's because the shiny is where the sac is, and then the one that looks all like lumpy and red, that's the one that's attached to the mom. And you can think of this as kind of like it's all rough because you have all those blood vessels that have attached to it. They're really tiny, and when they're tiny and there's a lot of them, it makes it look like rough. But the baby is in the sac, so you have the sac which is shiny, and that's on the baby's facing. So we have a star by that. Might be something you want to know. And then there's also another chart when you should go to the birth center. And that is on page 305. So regular contractions 5 minutes apart for 1 hour. And that is nullipara. Okay. And when you have the rupture of the membranes, you want the amniotic fluid to be clear and odorless. If it has like a purulent drainage or it's discolored, it could be a sign of infection. If it's kind of like greenish, it's meconium stained. And when it's meconium stained, the baby has an increased risk of infection because they could have inhaled that while they were still like floating around in mom's fluid, and then they can have like respiratory issues, like increased risk of infection. So you probably want to look out about that a little bit. Then there's conditions associated with fetal compromise. I'm not going to focus on that right now. Okay, impending birth. So here are some things that you probably should know. If the mom says the baby's coming, if they're making grunting sounds, like if they say that they have to use the bathroom and then they're in there and grunting, you probably want to like go in there and see what's going on, because she might be giving birth and the baby might fall down into the toilet. You don't want that. You don't want that. I've heard about stuff like that, and thankfully that didn't happen. Bearing down, if they just start like, bearing down, you want to make sure that they're getting some help there. Don't assume things can change very quickly. So maybe like she got checked and she was like 6, and then she has to use the bathroom and then she's in there grunting. Well, you probably, once you hear that grunting, you're probably going to want to go in there and just be like, hey, what's going on? Are things okay? Just check her out. And maternal positions for labor that has stalled. Here are 2 that you might want to pay attention to. These 2 highlighted ones. That's in the PowerPoints. And you're going to do your APGAR scores, and your 1-min APGAR you want at 8 or greater, because that's a sign of a good healthy baby. You're going to wrap them in a warm blanket, put on a hat to help with thermal regulation. You're going to want to promote normal respiration, support thermal regulation, stuff like that. And when you suction a baby, you want to suction the mouth first, then the nose, and that's because babies are mouth breathers. And once you put something up their nose, then they're going to want to take a deep breath in, and you don't want fluid in their mouth, because then they'll inhale it, and then you might have respiratory problems. And then for the fundus, once the mom delivers, it should be midline and at the umbilicus. If it's higher than the umbilicus and it's kind of like deviated to one side or another, then it's a sign that she might have a full bladder. Get her to urinate, and then see about like rubbing it and see if you can get it firm down, because if it's soft and boggy, then she could be at risk of a postpartum hemorrhage, because you need it to contract. There's all these loose blood vessels in there right now. And if the muscle fibers don't contract, then they don't seal those things off, and then she can bleed. So you don't want that. So you want to make sure that it's contracting. So you do fundal checks. You check the lochia. If she's passing an awful lot of clots, it's a bad sign. Really quick, we're gonna jump into chapter 20, because I think this is something that kind of like fits. You're gonna want to know this for the exam. So on page 396, this page here, the measurement for your for the lochia, that's something that you're gonna need to know. The instructor said, so scant is 1 inch, light is 1 to 4 inches, moderate is 4 to 6 inches, and heavy is 1 pad saturated in 1 hour. So there's a lot of numbers with this, and I've gotten it wrong last couple times, so I'm trying to do something different so I actually remember. It's just because there's like so many numbers, it's easy to get confused. So I'm using a little crude humor to help me remember, so if you don't like it, fast forward maybe like the next 2 minutes. So scant, the way I'm thinking about this is scant is like less than 1 inch. So if you have a guy and like the width is like less than 1 inch, that's kind of scant, Light, thinking of like flaccid, like 1 to 4 inches long. Moderate, you have like 4 to 6 inches, and that's about average. And then like if it's heavy, you have it saturated 1 hour, that's a big deal. You need to do some nursing interventions. So like do the fundal massage and things like that. So I'll go over this table 20.1 characteristics of Loki. You're also going to want to know that. So days 1 to 3, Loki rubra, it means red discharge. So normal discharge, you have bloody small clots, fleshy, earthy odor, red or brown. And like it can be brown because some of the blood's like old, so brown's okay. What you don't want is large clots, saturated pads, or foul odor. If you have like a lot of large clots, then that's a bad sign. And I think it might also be like, maybe like retain like placenta fragments or something. There might be something there. Don't quote me on that one. Then 4 to 10 days, Lochia serosa, and that's when it's starting to change color to more of a like a clear reddish, and that's when you're gonna serosanguinous, and that's when it's gonna be like a pink or brown tinged. You're gonna have it in decreased amount. All that's normal. What you don't want is continued or recurrent reddish color, and you don't want a foul smell, and you don't want an excessive amount. So by 3 to 4 days, you shouldn't have an awful lot of it. The smell should never be foul. If it's foul, it's like an infection. You need to get help for that. And once it starts decreasing, you never want it to go back to rubra, because when it starts going back to rubra, then it means it's a sign of new bleeding, and that's like postpartum hemorrhage. So after 1 to 3 days, no more red. It could be pink, but not red. Foul smell, you should never have that with Lochia. By 11 to 21 days, you have Lochia albia, whatever. May last until the 6th week postpartum, and basically what ALBA, what it means is it means white, and it's going to be white, creamy, or light yellow color. It's going to be even more decreased than before, and what you don't want here is you don't want persistent Lochia serosa or return to Lochia rubra. You don't want foul odor, and you don't want the discharge continuing. But it says you can have it until like the 6 weeks postpartum. So if it's like the 7th week and she still has it, maybe that's a bit of an issue. You also, like I said, once after like 1 to 3 days, no more red. You never want a foul odor, and it should always be decreasing in amount. Also, since we're on kind of like on the subject here with postpartum, they should also not have intercourse or anything until like after 6 weeks, when they typically have like their first like postpartum visit or something. They or maybe not their first visit, but like at 6 weeks they'll have a visit, and then like they can like kind of like talk with their provider about that, and then I guess their provider can be like, oh yeah, sure, get your kicks on, whatever. But you don't want them getting it on until like 6 weeks. And then also on page 397, there's box 20.1, lacerations of the birth canal. So you have 1st degree, 2nd degree, 3rd degree, and 4th degree. So you probably should know those. 4th degree, it's all the way through the anus and into the rectal mucosa. That's severe. That's bad. 3rd degree, actually let's go first. 1st degree. So the 1st degree is a superficial vaginal mucosa or peritoneal skin. That's, I guess, kind of common. 2nd degree involves vagina mucosa, peritoneal skin, and deeper tissues, which may include the fasciita and muscles of the peritoneum. The 3rd degree, same as 2nd degree lacerations, but involves anal sphincter. So I like to simplify this. So 1st degree, it's the periskin and vagina. That's it. 2nd degree, it's the vagina, periskin, and fasciita and muscles. So that's 2nd degree. 3rd degree, it's the vagina, periskin, fasciita, muscles, and the anal sphincter. 4th degree, it's busted through the anal sphincter, and now it's like it's going into your intestines, so that's a bad deal. So that's what you should know about that. Alright, let's see about going back into chapter 16 now. see, we got 20 minutes here. Alright. So let's see about if there's anything here. I pointed out. Okay, Bishop score. You want a score that is 7 or higher, and that's when you can actually induce labor. You don't want to induce labor before it's 7 because the cervix isn't ready. So it involves dilation, effacement, fetal station, cervical consistency, and cervical positioning. So each one of these has a score of 0 to 3. You want a score of 7 or higher before you induce labor, because if you induce labor and it's not ripe yet, then you're going to run into problems. And then also contraindications for induction of labor and also augmentation. You have placenta previa. You don't want to have them deliver when the placenta is blocking the birth canal, because then the baby isn't going to get the oxygen they need while they're in labor, because the very thing that's giving them the oxygen and the nutrients, it's getting destroyed as the cervix is opening up and as the baby's going down the birth canal. So that's one reason why you don't want to do a vaginal delivery with placenta previa. You're going to have a C-section. If they have like an abnormal presentation, then like our instructor mentioned, like a lot of providers, they don't want to do breech anymore, just because of like the complications. Umbilical cord prolapse. Well, that's because the umbilical cord is blocking the birth canal, so you can't really have them do a vaginal delivery or like speed it up or get it going if the cord's hanging out, because the cord's going to get compressed as the baby's trying to come out of there, and then that's going to cut off their oxygen circulation stuff. They're not going to do well. And if you have an umbilical cord prolapse, what you're going to do is you're going to go and use a gloved hand, stick it up there, and put pressure on like some of the fetal parts, so that the cord's not getting the pressure, and the baby can still have the circulation. And then you're also going to go catch a ride, and then you're going to go down to like get a C-section right away. Previous uterine surgery. So if you have like a C-section before, and then a lot of times they don't want to do a vaginal delivery if you've had a previous C-section, because that area where they cut, it's weak, and when you have to have all that contraction for a vaginal delivery, you could have uterine rupture. That's why they don't want to do it if you've had like a previous C-section before. Non-reassuring fetal heart rate pattern. So labor is tough on a baby. So if a baby is not having reassuring signs, you don't want to like put it through all that stress, because it might not do very well. So the risks of induction or augmentation, you have uterine hyperstimulation. So then you can have I think it's called a uterine tetany, maybe. Let's see here. Chapter 19. It should be this one. Uterine tachysolate. So yeah, it's just when they're like hyperstimulated, it's just too hard on the mom. And also, like, if it's like really putting a lot of pressure, then the placenta doesn't have any time to actually get the oxygen and nutrients across, and then the baby can have like late decels, things like that. So that's like, if you have a baby that has late decels, that's one of the first things you're going to do is cut off the oxytocin, because that's gonna hopefully like reduce the contractions that the mom's having, and give the placenta and the baby time to recuperate. Also, it can just be like really painful if she's having like these really hard contractions. Uterine rupture, that's another risk. And also, like, if you have like twins in there, if you have like polyhydramnios, like if it's just like really big in there, or you have a baby that's like 4,000 grams, you can have a uterine rupture just because it's like so big, and then it's trying to like push and it just can't take it. And then also maternal water intoxication caused by oxytocin's antidiuretic effects. Greater risk for infection of your chorioamniotis or something, and C-section. So if it's started, you could have a risk of a C-section just in case it's like not ready or something. And then oxytocin is given diluted in fluid. So I don't really have any other notes that I've gone through to like just like pay attention to. So. And then also signs of uterine oversensitivity that you're gonna probably want to pay attention to since there's a star beside it. See if I can find it in the book. I don't see where it is in the book. But it's contraction duration of longer than 90 to 120 seconds. Contractions that occur less than 2 minutes apart, or relaxation of less than 30 seconds between contractions, and fetal heart rate pattern of late decels accompanying hypertonic uterine activity. So what you're going to want to do for this tachystoly, you're going to want to reduce or stop the oxytocin infusion, probably stop it. Increase the rate of primary non-additive infusion. So like if you have like lactated ringers going or something. You're going to keep the laboring woman in a lateral position because that promotes the placental transference of like nutrients. So you're going to want to do that. Give oxygen by snug face masks, 8 to 10 liters per minute, and notify the physician or the nurse midwife. Just trying to find out where it is. Okay, so that's on page 382. So, and then if they do aversion, you're going to want to monitor them for 2 hours after aversion. They're very painful. Assess for contractions and discharge. Don't send them home right away. And then probably use tributaline just to relax the uterus. And they can have flushing and hot flashes, which are normal, and also they can also have a heart rate under 110 beats per minute, I guess. So, yep. So you're going to want to monitor the fetal heart rate. Monitor 2 hours after the version. And you're also going to want the IV ready as well, just in case they need other medications or anything like that. Okay, let's see. Alright, so I think I'm just going to take a break from OB. That's some of the stuff I just wanted to cover since that's what I'm studying, and maybe there's like some stuff in here that can help with our exam. So I just wanted to go through some of that real quick. Alright, let's see where my notes are for hypertension. Okay, so for the pharmacology exam, some of the medications that I want to focus on are the hypertensive medications. So like your Pharm guide for the meds for hypertension. So the thiazide and the loop diuretics, they're pretty similar. You're both going to get hypokalemia because it's not potassium sparing, and you can both get dehydration because like if it's to like lower blood pressure and things like that, then they work by having you pee. So if you're peeing a lot and you don't have enough like good intake and you're not like maintaining it, then you can have dehydration. But you're gonna have to worry about hypokalemia and also hypotension. So like orthostatic hypotension. So you're gonna want to teach them about like don't make position changes suddenly, dangle before you rise, that sorts of thing. because you don't want to have them like stand up really suddenly and then like in 5 seconds they get dizzy and then they fall down and they hit their head. That'll be a bad sign. So, and also they can cause hyperglycemia, so we're gonna also like want to like know our lab values and stuff. So the normal potassium range is 3.5 to 5, so that's what you want their normal potassium to be. Hyperglycemia, that's anything over, like our normal range is like 70 to like 110 depending on like what lab values you look at. So if it's like, you know, like 120, then they probably have hyperglycemia. Okay. So if they have hypokalemia, then they can have like weakness, and they can also have dysrhythmias. So those are some things you're going to want to monitor for. You want them to have foods that are high in potassium, so like bananas, potatoes, tomatoes, and spinach. So watch out for those. And also with loop diuretics, they can have ototoxicity, and one sign of ototoxicity would be like ringing in your ears. So they're like ringing in their ears and they're taking like furosemide or butymetane or butymetide, then that's bad. Because the loop diuretics, they can cause ototoxicity. Ototoxicity, one of those signs is ringing in your ears, so you're gonna want to watch out for that. Yeah. So the thiazide, they end in the thiazid. Loop diuretics, an extra side effect that they have is ototoxicity. Yeah, get out of bed slowly. So some things with medications I like to do is, because there's so many side effects, I like to make these like mental images, and it's a way that you can kind of store a lot of information in like a relatively short amount of I don't know, storage you might say, because you, instead of like thinking about all these different units, you're just thinking of one picture. So that kind of helps. So so with the thiazide and the loop diuretics, I'm thinking of, you know, like you just have like this person, maybe they have like their characteristic of like having hypertension. So I'm thinking of for the thiazide and the loop diuretics, this person sitting on a toilet, because I don't want them standing if they have like, you know, hypotension, you know. And I also want them to rise slowly. So I'm thinking of them like they're sitting on a toilet because they have to pee a lot, because that's what the diuretics do, and they have a glass of water on the bathroom counter because they have to watch out for dehydration. And they also, like if they're hyperglycemic, they're also going to be thirsty because their body's trying to get rid of that excess like sugar. So you can be thirsty if you have hyperglycemia, and you're also going to be thirsty because these can cause dehydration. And because these are not potassium sparing, he is peeling or peeing just, you know, with a banana. So it's a way of like saying like, okay, you need to have potassium. You're going to be peeing a lot. You should watch out like with your fluids and stuff. And also, you really want to watch out for orthostatic hypotension. We want to teach them about that. Teach them about making sure that they have potassium, making sure that they're drinking enough. Like if they have dry mouth, then they're probably dehydrated. So those are some things. And then also with the loop diuretics, one extra side effect is ototoxicity. You're gonna want to like monitor for like ringing in the ears. Potassium sparing, on the other hand, these guys are kind of unique. They can cause hyperkalemia because they keep the potassium in your body. And they also have impotence in males and menstruational irregularities in females. So what we're going to want to do is we're going to want to monitor their potassium. So if it's over like 5, then it might be an issue. And we also can give insulin to drive potassium back into the cell. Like if they just like have like hyperkalemia and it's like a big issue, like then in an emergency situation, or just like if need be, then we can give insulin to drive the potassium back into the cell. So one mental image I'm thinking about for the potassium sparing diuretics is you have somebody that's just like lying on a couch because they have orthostatic hypotension. You don't really want them to like stand around because they could fall. and their banana is covered with the condom. And the reason I use that mental image is because we don't want them having banana. It's just not a good deal. It can give them too much potassium, which can lead to hyperkalemia, and that can just, really cause dysrhythmias with their heart, and we don't want them to have like heart attacks. So, yep, no banana. And also, it can cause like impotence, so you're not gonna, might be a little bit of an issue there too. The other medications that we focused on quite a bit that I think are worth taking a look at are the beta blockers. So those are LOL, like laugh out loud, ha ha ha. They block the heart. So you're going to want to monitor their heart rate and their blood pressure before you give them. And if they're like less than 60, you don't want to give them. And if their blood pressure, if the top number is like less than 90, I think one of our instructors said, you probably don't want to give them either. So some of the side effects of these are bradycardia, because it blocks your heart, so it's not going like as fast. It's like going like slower, and like sometimes it can be too slow. Bradycardia. Decreased cardiac output, because your output's measured in part by like how much you get out of here. So if it slows it down, you're not going to have as much cardiac output because it's slower. As I mentioned before, orthostatic hypotension, and it can also have, for beta-2 blockers, you can have bronchoconstriction. So the beta-2, they affect the lungs and the heart, so you might want to like watch out for like respiratory issues if a person's taking beta blockers. And then like if a person's like a diabetic, the bradycardia, it can the bradycardia caused by the beta blockers, it can hide tachycardia if a person is has hypoglycemia. So that's also something maybe you want to pay attention to. Next we have our angiotensin inhibitors. So angiotensin, they work by like angiotensin is like angio, artery, tensin, makes it tense. So the angiotensin, it constricts your blood vessels. It makes them like smaller, and then that's going to increase your blood pressure because there's a smaller like volume. So like if you don't have enough blood volume, they can make it smaller so that you still maintain blood pressure. If you have a lot of blood volume going on, then it makes it bigger so that your blood pressure is maintained. But if you have like atherosclerosis, or if you have like coronary artery disease, it's going to affect your vessel's ability to like, constrict and dilate. And then you can't regulate your blood pressure as much. So the ACE inhibitors, they work by causing vasodilation, because they block that enzyme, and then it doesn't it keeps them open. It doesn't vasoconstrict, it keeps them open. So angiotensin inhibitors, artery tense inhibitors, so they're open. First dose, orthostatic hypotension, hyperkalemia, hypotension, dizziness, stuff like that. So aspirin and NSAIDs reduce effectiveness. Diuretics can increase effectiveness because they're already working to decrease your blood pressure by getting rid of the blood volume, so of course they're going to increase the effectiveness. And also, because these are inhibitors, that they're blocking like certain enzymes, they also inhibit the breakdown of certain it's like a protein chemical, something like that, and because that can build up, you can have a dry hacking cough, and that's something you don't want, and you're going to want to have it like reported to the healthcare provider. Do not use with potassium sparing diuretics because it can cause hyperkalemia. So you have this that can cause hyperkalemia. If you have potassium sparing diuretics, then you have hyperkalemia and hyperkalemia. Bad news. So probably the biggest thing is about like a cough. So angiotensin, they're inhibitors, so vasodilation, they're also inhibiting something else, which can cause the cough. And then you have angiotensin receptor blockers, ARBs. They're may not be effective for 3 to 6 weeks, maybe given with or without food. These guys are a little bit different. They also result in vasodilation, but they do not cause cough. They do not cause hyperkalemia. The first dose, you can have orthostatic hypotension, you can have dizziness, renal failure, rash, and angioedema. So if they have like face puffiness or something, that's probably something you're gonna like want to notify somebody about. Then the calcium channel blockers, they end in IPINE, and you have these things like affect the contractibility of things. So you can have bradycardia, reflex tachycardia, orthostatic hypotension, and dysrhythmias. So you're going to want to monitor their blood pressure and heart rate before you give these things. And you might have these working with a diuretic just to help with the peripheral edema. That's a side effect of these. And then like as like all these medications that affect blood pressure, you're going to want to notify them or teach them about orthostatic hypotension, like rise slowly, things of that sort. So, and then there's also like some other like side effects of these, so just go through that like hypertension chapter and then just kind of like look at these a little bit. And then the ARBs, they end in sartan, and the angiotensin inhibitors, they end in pril. So pril, you cough, so I'm just thinking about, like pril, you cough. Sartan, those are the ones that do not have the cough and hyperkalemia. They do not have them. And then you have your calcium channel blockers. So I think that's all we'll cover. It's about 42 minutes. So I hope that this kind of like helps. If it doesn't help, or if there are just things that you think could change, just let me know and then we'll see about it. So anyway, I hope it helps. If I can think of like some other ways to like remember some of the blood pressure medications, I'll definitely see about doing that. But so far, that what's kind of like helping is just dividing them up into certain categories, and then also looking at the last names. It really does help. And also, while we're here, like grapefruit juice, you should not take it with losartan. That is a, just want to get it right, that is an no, that's an ARB. So you don't want to take grapefruit juice with losartan, and you don't want to take them with verapamil or neferapine, and those are both calcium channel blockers. And then you also don't want to take it with fentanyl, which is a pain medication. And then you also don't want to take it with statin drugs such as simvastatin or avorvastatin, because the grapefruit juice, it just can mess with medications so that they build up to toxic levels. So that's some stuff that you're going to want to know. And then I'll see about maybe getting another study video out soon. So have a good night. Bye.